Good afternoon. First of all, it's a pleasure to see all of you again. I have truly loved and enjoyed my experience supporting the SAGES JSES relationship, and we've been doing this for many years now. And I look forward to coming back to Japan to the IPEG meeting this May. So the task was to talk about what are we doing in simulator training. And here are my disclosures. They're not relevant to any of this. This is Welcome to Buffalo. This is the view of Buffalo from the water. I've still have a house here in Boston, but I've left Harvard, and so this is where I am now. It has a vibrant nightlife, building a new medical school that you can see in the center, and we are the home of wings. If you want to talk like a native, they're not chicken wings, they're just wings, and all of you are invited to come. Hope to set up some bilateral visits between Buffalo and Japan. And if all that wasn't enough, we have the falls. So when we talk about simulators, you know, anybody can make a simulator. And so what I like to start off with is talking about what makes a good simulator, and it's the validities. And there's a lot of different things that we think about when we want to build a simulator. It needs face validity. It needs to seem like this is a reasonable approximation of what we're trying to accomplish. It needs construct validity, the degree to which the test actually measures what it claims to measure. So first one is sort of a sniff test, the second one is a measurement test, and last is a content validity. If you do work on my simulator, will you actually get better at surgery? So you can make a brilliant simulator, but if it doesn't make you a better surgeon, it doesn't have any construct validity. And of course, predictability. Does it make the actual outcome of the surgery? Not only can you do it better, can you provide a better surgical outcome? So predictive validity is the ultimate. So in aviation, simulators are so good that you actually get credit for flight time. I'm a pilot, and some of my logged hours were actually in a simulator. Why can't we do that? If you can go low tech, is on the left, where you can just buy that out of the box. You can go high tech in the middle, where a guy actually bought part of a console from an airplane, bought 6 computer monitors, and built his own little simulation cabin and made that at home. Or you could go what commercial pilots do. You can't tell the difference between this and a commercial cockpit. Simulators are so good they can actually save lives. And if you don't believe me, if you're an Apollo 13 fan, if you recall the movie, it was Commander Mattingly who had to stay home because he got exposed to the measles. This is the real Commander Mattingly, and this is Gary Sinise in the movie, actually sitting in a simulator working out the sequence where they wouldn't use up too much power to make it home in the Apollo 13 module. The simulator saved the lives of the astronauts. So why can't we have that? But to a certain degree, I would think that we do. We have all this registration, activity and imaging, some of what you just saw, which is really kind of brilliant stuff. It's the soft tissue that's hard to simulate. Liver, kidney, spleen, to some degree lung, but moving the guts around, if you do a CAT scan, they're not going to be in the same place as where you left them. So that's a problem. We do skill training. We do open skill simulation, laparoscopic, endoscopic, and we simulate procedures. So what do we have? All different kinds of simulators. We have physical simulators. Moving a peg transfer in FLS is a physical simulator. We have computer-based simulators. If you went to the Learning Center and saw the VEST virtual endoscopic surgical electrosurgery trainer, that's purely a computer. We have hybrid simulators that use both computers and some physical aspect, and we also have team simulators where we actually simulate teamwork. So in the physical simulators, the one that we talk the most about is at SAGES is FLS. FLS is the only validated surgical training program in the world, has been shown to correlate with skill outcome review. If you watch a video, anonymous and blinded reviewers score the FLS trained people higher than the non-FLS trained people. And yet at the same time, it's hard to show an outcome of an actual operation. And so while FLS has high construct validity, which is why it's required by the Board of Surgery. It's hard to find a patient who you could actually survive because of FLS. So that's still more holy grail to come. But that's not the only physical simulators. Since JSES is both endoscopic and laparoscopic surgery, there are physical types of simulators. Here's an explant of a stomach. So this is tissue-based simulation of upper endoscopy, or you can do it with PVC piping, more physical simulators to simulate endoscopy. Another type of simulation is simulation of open surgery, and the American College of Surgeons has done great work in trying to simulate trauma surgery using live animal models with simulated trauma injuries. So this is a form of simulation. You used to call it animal lab, but really it's a form of animate simulation, simulating traumatic injuries to improve outcome in real human patients. So I ask you, with all of our physical simulators, what's better? Going to the slaughterhouse and getting some bowel, kind of messy, you need to Clorox it, or just using some stuff from any one of the manufacturers who make that stuff? Hard to say, hard to measure. But we know practicing on either one of these is better than no practice at all or trying to learn these skills in the operating room. What about virtual reality? So our group, we have a consortium of people, and we have a number of National Institute of Health grants, and we've built something called VBLAST, Virtual Basic Laparoscopic Skill Trainer. And so VBLAST uses phantoms, that's these things here, with haptic feedback. And VBLAST, you can actually move all the same peg transfer and pattern cutting and loop and suturing all in virtual reality. So there's nothing down here. There's no wizard behind the screen, and everything you see is simulated in virtual reality here. And we've done studies to show that VBLAST training actually can improve skills in the operating room. So here's VBLAST. Maybe. So this is what the virtual skills look like. This is all virtual reality. They're working on those phantoms. And you get haptic feedback. So unlike working on a robot where there's no haptics, there's actually haptic feedback in the VBLAST. So this was running a little bit slower than what it is in real time. And it's still not perfect. Virtual reality, in some ways, is better than practicing with physical skills for one reason. You can do automated scoring. Here's our cutting task. It looks almost like a real piece of gauze, but this is all virtual. Kind of moves and wiggles and waves around like gauze. You see how the little wiggle there? That's all part of the programming. And you can do the pattern cutting test. Now, one of the hardest parts of FLS is doing the scoring because it requires a very expensive proctor to stand there and score. With VBLAST or other automatic scoring systems, you can take the proctor out, the most expensive part, and do it all by computer. So this part is pretty hard. And in a second, I'll show you the really hard stuff. All that's simulated. All that's happening in the phantoms up above. The suturing is the hardest part of all because you have to mimic the motion and the physical motion of the suture. That is really tough stuff. High levels of programming, and we still have a ways to go before it's as good as doing the real thing. But you can see, you can learn to tie a knot. You can do it all virtually and get timed, get motion path metrics and things like that. So now what's better? Doing it on a real piece of bowel from a pig? Doing it with a foam or plastic model? Or should we be doing it virtually to come up with the scoring? And still the jury is out, but these are what the possibilities are in training simulation. Now we could take this one step further, where we took our VBLAST and stuck it in a virtual environment, like Half-Life. And this is what I like to call V squared, virtual in virtual. And here we are, we have a different grant for this. We have a person in a virtual operating environment. The person who's in the physical world is moving the sticks, and what they're doing is in this virtual world moving the pegs. So it's virtual in virtual. And in theory, you could do this for team training, and people wouldn't have to even be in the same hospital. They could all be on the team working on a virtual patient in multiple locations. Here's our computer-based thing. Here's VEST that I talked about a moment ago. Here we are. We took the physics of the real world, where we've done real studies of time and temperature, working on liver and spleen. And you can see here, this is what your real bovie temperature is. And you can measure all of these things. And this is actually better than physical models, because we can link this to histology. We can link this to all different kinds of real-world tissue. And we put this up on TED. Also in our virtual environment, we can do patient safety. We have a virtual fire scenario, so we can teach people how to prevent fires, all in virtual reality. Now, we can also do this with physical models. So here's the physical model of those same electrosurgical skills, and you can do it with meat. But again, you got to buy the meat, you got to set it up, it's messy. But you can do it both in the physical world and in the virtual world. Now, we also talk about simulation for robotics. So there's a number of robotic simulators. This is the Ross simulator. And you can see these are simulated robotic skills. So it's device agnostic. And you can see that you can do knot tying, and you can do all different types of skills with this. Or you could use the backpack simulator from Intuitive and do training. And the problem is these tools change. You know, the simulators have to keep up, and the programming is extraordinarily complicated. And again, you can do suturing skills and other things. Now, what about the procedures? Where are we with virtual training for procedures? And the problem is VR is good for junior residents. So if we look at this as one of the common procedural simulators, and you can see the electrosurgery taking off. If you're an experienced surgeon, you have to unlearn real surgery to do this on the virtual simulator. So this is good for early stage trainees that need to be verified that they know all the steps and in the right order. It's not so great for experienced surgeons to test proficiency. But if you really want to turn it into a game, there are other opportunities that you can get. So this is learning how to do a heart transplant from the game Virtual Surgeon. And you can see that maybe the reality is got a little ways to go. They're trying to get to the heart, and so they're going to just sort of move some organs out of the way. I'm sure that's how you do it in your operating room every day, and they measure blood loss. So if it's the organs in the way, they just throw it out. So if you get on the internet, people love it, but it's not that useful for training surgeons. On the other hand, nothing beats the real thing. So if you want to really practice how to do a colectomy, some people would argue you should practice in a cadaveric model. We're very fortunate at the University of Buffalo. We have a large anatomical gifts program, and we can do cadaver models almost as, or even less expensively than someplace does animal models. And this is doing a nephrectomy. And if you want to practice the steps of the nephrectomy, it's better than a pig because the animals dissect way too easily. This is much more lifelike. It's particularly good for colorectal surgery and robotic simulation. Now, how do you survive a crisis? So I want to show you, I'm a pilot, so I like to go back to aviation. And I want you to watch this plane. It's going to come down. It's going to come down. They're having gale force winds. It's going to touch the ground. And they go, no, no good, no good, no good. How do you think they manage that? It's not done by one person. It's done because a team practices. And so our ultimate thing that we need to really move to in the world of surgery is how to make our team better. You heard Dr. Duncan talk today at his presidential address about the importance of teamwork. So we can do this laparoscopically. We have started to build environments where at the Beth Israel Hospital, when I was still at Harvard, Dan Jones and his crew did laparoscopic team crisis training and simulated a real live surgical emergency. That's not a real operating room. That's in a sim center. It's got labs. This is John Critchlow as the subject. It's got an anesthesiologist. It's got actors. It's got crisis. It's got falling blood pressure. It's got people monitoring in the booth. And it's pretty good. But I didn't fully appreciate the value until one day a patient was coding in the operating room next to me, and I came to realize that the poor urologist had never seen life-threatening massive hemorrhage, and he had no preparation for how to manage a team in a crisis. Laparoscopic crisis team simulation is something that you ought to be thinking about for the future. So in summary, the VR, the physical, the animate, the inanimate simulations all have a role in surgical training. The VR is awesome, but it's not perfect. It's pretty good for skills. Procedural training is still a work in progress, but nonetheless, hospitals must invest in simulation in order to improve the safety of our patients and improving the care of the teams. Thank you.